Hi, this is Annie Kennedy with PPMD, and I'm joined today by Ryan Fisher of PPMD and Mike Adelberg of Faegre Baker Daniels. And this is a part of PPMD's Access Resource Center. This is a webinar that's aimed at becoming another part of the tools or the toolkit, which is armed to empower our community members to navigate this complex access environment. Today's webinar is part one of a two-part webinar series entitled Fundamentals of Access to Duchenne Therapies. In this particular webinar, we'll be exploring drug approval and health insurance overviews, including types of insurance coverage, concerns about both health coverage and drug coverage. And then the subsequent webinar will delve a little bit deeper into navigating health insurance to improve access to specific therapies, which will include drug formularies, advocating within the health insurance system, and financial assistance. So without further ado, I'd like to introduce our expert presenter today, Mike Adelberg. Mike has over 20 years of experience with public and private health insurance programs. Before joining Faegre BD, he served in senior positions with the Centers for Medicaid and Medicare Services, CMS, including as Director of the Insurance Programs Group and Director of Medicare Advantage Operations. In the private sector, Mike led health policy affairs for Universal American Corporation and as an advisor with Bearing Point. His practice focuses on advising clients on Medicare, Medicaid, and health insurance exchange matters, and we're very grateful to have him as a part of the team that helps to advise PPMD and our Duchenne community on matters related to access as a part of the Faegre team. So, Mike, we'll turn this over to you. Thanks so much.
Okay, thank you, Annie, and it's a pleasure to have a chance to speak with you and the Duchenne community on this really important set of topics. Before getting into the slides, I know we're at a very important time in healthcare reform, and I did want to take just a second to talk a little bit about where we are. Many of you likely know that the House has already passed a bill that would create an alternative healthcare financing program for to replace the Affordable Care Act passed under the Obama administration. In a nutshell, what the bill will do is change the financing of Medicaid being government-financed healthcare insurance for people with limited incomes, and also reform the individual market or the ACA market by replacing it with a series of age-tested tax credits where we presently have subsidies, and creating greater flexibilities and funding for states for people with expensive health care needs and pre-existing conditions. The House bill has been sent to the Senate. The Senate is considering the bill and is developing its own bill, which in many ways will probably be substantially different. Assuming the Senate passes a bill, that bill will then become the subject of a House-Senate conference. Both houses will look at the conference bill and ultimately determine to pass or not pass it. If the conference bill would pass both houses, it would be sent to President Trump for signature. All of this will happen over the next several months. The passage of this bill is not a foregone conclusion. And until that occurs, it's important to note that the ACA, the Affordable Care Act, or Obamacare, does remain the law of the land. With that, I'm going to get into our opening discussion. And as Annie noted, we're covering two big topics on today's call. We're going to talk about how drugs get approved and brought into the marketplace, and we're going to provide an overview of health insurance. We'll talk more about both of these topics tomorrow. Okay, first a discussion about drugs and the drug approval process. We're going to talk a little bit about the clinical trials that a drug manufacturer goes through to bring a drug to market. We'll talk about access to drugs, the relatively few cases where people with high and acute drug needs can get access to drugs prior to approval. And then we'll also talk about how that transition period where a drug goes from approved to widely available in the health insurance market. So let's start by discussing clinical trials. There are three distinct stages of clinical trials that a drug maker goes through to determine that an experimental or investigational drug is in fact safe and efficacious. The clinical trials, make no mistake, can take a long time. They can be very expensive. And a great many drugs that begin clinical trials do not ultimately prove successful during those clinical trials and never make it through. To find out about clinical trials and the ability for a person with a disease, perhaps Duchenne or another, a patient undergoing therapy who might be interested in getting access to an investigational drug. To find out about those, PPMD has a very good tool focusing on Duchenne-related clinical trials called DuchenneConnect.org. And there's also the federal government's tool, clinicaltrials.gov, which covers a much wider range of clinical trials. To qualify to participate in a clinical trial, a patient has to fit the particular parameters of that trial. In other words, the patient would have to have the symptoms that are being tested, or the remedy of them that are being tested. They have to have the disease history consistent with the design of the trial, and they have to meet the logistic and location needs of the trial, in many cases being co-located with trial sites, and et cetera. And then there's a considerable amount of informed consent that goes into this. The patient must understand that there are risks potentially to participating in the clinical trial, and they must understand that the drug is not approved and might not be helpful. Again, as I must underscore that the majority of early stage clinical trial drugs do not ultimately make it to market. So while there are many people who work very hard because they are searching for the best possible therapy to the disease that they may have, they work very hard to get into clinical trials, but being in a clinical trial does not necessarily equate with a cure. And particularly for more rare diseases, the drug manufacturers and the researchers who are under certain obligations to put together population sizes for these trials can have their trials extended considerably as they struggle to do the recruiting necessary to begin a stage of the trial. So with that, I'll just note again that this can take a long time, and there's a highly scientific process resulting in papers being written by clinicians, reviewed by clinicians at other places through peer review, and then ultimately going through the Food and Drug Administration for consideration on the path to approval. A quick note about drug coverage while a person is participating, insurance coverage while a person is participating in a clinical trial. If you are participating in a clinical trial and you have insurance, the insurance in general is required to continue covering all routine costs, irrespective of your participation in or out of the trial. In other words, the insurer cannot transfer costs onto the trial administrators that the insurer would normally cover. Talk a little bit about another way that outside of clinical trials that people do get access to investigational and experimental drugs, and that is through the FDA's expanded access program, often called compassionate use. The compassionate use programs that the FDA runs are not widely used. They are the subject of a considerable petition process, and ultimately a little bit more than 1,000 people a year petition the FDA successfully and do get access to investigational and experimental therapies through the compassionate use program. We'll talk a little bit about the details of that now. Importantly, this petition process begins with the physician. The physician is the entity that actually petitions the Food and Drug Administration on a standard form called the 3926. And the number of criteria must be met to petition successfully, including an argument that no satisfactory alternative therapy exists, noting that there is no other way for the patient to gain access to the investigational drug, a discussion that the benefit of the investigational drug is greater than the risk associated with the investigational or experimental treatment, and also noting that the participation in the expanded access program will not in some way interfere with the clinical trials that may also be going on with the same drug. In general, the FDA is more likely to approve drugs through this program that are in the latest stages, stage 3 of clinical trials, because those are the drugs that the FDA has greater confidence in than the drugs at the earlier stages. It's also important that the FDA believes that the chance that the drug can do harm is minimal. Even if the FDA approves the petition, the drug manufacturer must concur with with dispensing the investigational drug to a patient or a set of patients that have petitioned. And in some cases, the drug manufacturer will turn down the petition because the drug manufacturer might not be ready to turn over certain information to the FDA, including information related to the cost of the drug, or the drug maker may have concerns itself about the potential harm that the drug might cause.
Mike, this is Ryan. Typically for these expanded access considerations, who covers the costs for the drugs?
The FDA can choose to cover the cost of the drugs, and we'll talk a little bit more about right to try laws, which are equivalent in some ways in terms of getting access to experimental and investigational therapies, but the patient, in the event that the manufacturer will not cover it or the FDA will not cover it, very often the patient may choose to cover it him or herself with, in some cases, the support of private charities. And so let me pivot to talk a little bit about right to try laws now. Currently, 37 states have a right to try law of one type or another. The goal here is to provide patients usually with terminal diseases who are not getting those terminal diseases treated successfully through existing therapies, to give them access to drugs that are in clinical trial and otherwise experimental. Most of these laws do require that the drug at least be in stage 1 clinical trials, and these laws do not tie the manufacturer to providing financial assistance and make manufacturer participation voluntary. There is not a reliable study on how many people are presently accessing drugs through these right to try laws, because they are by nature individualistic decisions made between particular patients and particular drug manufacturers.
Mike, without spending a lot of time talking about the side-by-side, can you just spend a moment, though, talking about there are some differences between the regulations around safety data and tracking of safety outcomes through expanded access and through the proposed federal right to try legislation? Can you just spend a minute talking about what that looks like?
Sure, Annie. As you discussed, there are currently bills. There are bills in Congress to create a federal right to try program. Senator Johnson of Wisconsin has been a leading proponent of creating a federal law, and it is worth noting that the expanded access program under the FDA is a federal program that does collect data and does have tracking and consumer protections built into it. It's less certain what type of infrastructure would accompany the federalized right to try program.
Okay, thank you. Okay,
All
so
right.
after approval.
Yes.
So assuming everything's gone swimmingly, God willing, and we're now approved.
Yes, so we get a drug all the way to approval, and this, as noted, this can take a little bit. But when a drug gets approved, it gets assigned a unique identifier for billing and tracking purposes in NDC code for most drugs. And then the drug manufacturer begins to market the drug to get it covered and to build interest in the drug. And of course, in the case of certain drugs, particularly for rare diseases and severe diseases, the patient advocacy community is already tracking these drugs through clinical trial. But upon approval, the drug manufacturer will market to the insurers, payers, looking to get their drug put on the drug formulary. And we'll talk more about formularies in webinar 2. Also marketing to the healthcare providers, and particularly the physicians who will write the script, and in some cases, direct to consumer. Those television commercials that you'll see for certain drugs that include lists of potential adverse side effects that sometimes can take longer than the rest of the commercial. That is because there are a number of restrictions that the FDA places on direct-to-consumer advertising. But having said that, drug manufacturers have determined in many cases that direct-to-consumer advertising is still an important way to get the word out on their newly approved drugs. It is worth noting that with this marketing, there are restrictions on how the drug can get marketed by the manufacturer, and in particular, the content of the advertising must be close to the on-label approval that the FDA has granted to the drug manufacturer in terms of discussing the context in which the drug is in position to help patients, and also including making clear what the potential adverse side effects of taking the drug could be.
So before you move off this slide, and I recognize that there's a lot that goes into the back and forth between the drug sponsor and the FDA and the target product profile, et cetera, but so much of what we're going to be talking about going forward will surround that FDA label and what's considered on-label versus off-label. Can you just maybe in very general terms talk about how it's determined what's on the label beyond that the drug's been created for, say, the Duchenne community? How is it decided what segment of the Duchenne community benefits and what other safety information or information goes on the label? Who decides that, and how does that ultimately get determined? And what is the intended use of that label? Because I think so much of what we're going to talk about now when we talk about reimbursement decisions hinges on that. Can you just talk a little bit about that label itself before we go any further?
Yes, although, first of all, it's an excellent question, Annie, and an important one. And while I'm happy to discuss it, I would hasten to offer two caveats before getting too deep into this topic. The first is that much of the discussion around the final specifications on labeling and what the drug is the appropriate uses of the drug get very deep into specific clinical and scientific questions that get a little deeper than we probably should get on this webinar. Mm-hmm. And then second, to just note that these conversations really can vary a great deal from drug to drug. And this is a topic in which the FDA and the drug makers and the researchers associated with the final stages of clinical trials can disagree, and sometimes intensely disagree, as to what the final specs should be for that label. Having said that, the label is extremely important because this outlines what, in the FDA's opinion, is the appropriate use of the drug. So populations may be articulated, particular populations even within a community that has a particular disease, stages of the disease's progression, particular symptoms of the disease, whether there may be particular drug-drug interactions, a variety of comorbidities and other factors that might make the drug less useful or even harmful. So there can be, and this all comes out of the clinical trials, and all of this can limit the use of a new therapy. And we'll talk a little bit about cost tomorrow, but irrespective of cost, a drug can be approved, but approved in only a very narrow context. And this is the type of information that, coming out of the clinical trials, the FDA and the manufacturer will finalize a set of conditions around which the drug is most appropriate.
That's great. Thank you. And just to maybe add another layer specific to our Duchenne community, when PPMD worked on the Duchenne community-led guidance, one of the elements of that guidance was that we really worked with the FDA and worked with the community to really push for broad labeling. So that being when there was a very limited subset of the community included in the clinical trial because of the inclusion criteria required based on the endpoint utilized in that trial, that if the safety data was strong enough that broad labeling would be considered. So in the approvals that we've had thus far, the FDA, we've seen this. We've seen that while there was a subset of the population included in the trial, so maybe ambulatory boys within a certain age range, that if it looked like there could be benefit for a broader array of the population who are amenable to that exon skip or that mutation, that the labeling would not have an age cap on it, even though the clinical trial did. However, we are not necessarily seeing payers follow the labeling as far as reimbursement goes. So this may come up again in discussions tomorrow when we're talking, or in our future webinar when we're talking about navigating access. But I think the labeling has been such an important issue for our community. But we are seeing FDA apply what was reflected in both our guidance and then their guidance back, the draft guidance around Duchenne to industry. So just another layer to put into that.
Thanks, Annie. Those are excellent additional thoughts, and it underscores the really important role played by patient advocates and patients in seeking to have the widest possible, the widest scientifically appropriate scope for the drug as it comes onto the market.
And then just one more question beyond the label. After approval, how long does it usually take for a drug or a therapy to be available for use by a patient population once that product's been approved?
It can take several months in that the formulary decisions made by insurers are frequently annual. And depending on when the drug comes on the market and the position of the insurers in terms of approving and making edits to their formularies, it could wait several months for the next insurance year or for the insurer's P&T committee that considers coverage decisions to amend their formulary. There will be times, however, when the insurer is expecting the drug to be approved and is ready to make a mid-year formulary change to make room for the incoming drug. So an insurer can move quickly when it's excited about the arrival of a drug and well prepared for it.
Okay, great. Thank you.
Okay. So when the insurer makes the decision to cover the drug can be covered in different ways. And most drugs are covered through the pharmacy benefit that's offered by an insurer. And the pharmacy benefit applies to the large number of scenarios that most people think of. These are the drugs that a patient or a consumer takes orally at home. They're picked up at the local pharmacy. If it's a long-term med that someone's on a predictable prescription year after year, it could be through mail order. But these types of drugs are the subject of insurance coverage. There'll be coverage rules governed by a formulary. There'll be payment rules governed by the benefits of the particular insurance product. There's an increasing number of drugs, however, that are not covered through the pharmacy benefit, but are covered through the medical benefit. And the principal reason why they're covered through the medical benefit is because they're delivered at a physician's office. Many times these drugs are injectables, though not all of them are injectables, but they are, because they are delivered at a physician's office, they are covered under the medical benefit and subject to the cost sharing associated with a physician's visit rather than with picking up a drug from the pharmacy. And there's again a small but growing number of drugs, and usually expensive drugs that are the subject of what is frequently referred to as specialty pharmacy. And these are drugs that very often are delivered straight to the patient, but because they are expensive and very often life-saving or life-extending drugs, when they are delivered to the patient, the insurer or the insurer's agent, the pharmacy benefit manager, will make contact with the patient and assure that the patient knows exactly how to self-administer the drug, will record certain results after the drug is administered. And so you might call it a hybrid of a traditional pharmacy benefit and a medical benefit, because while it is self-administered, there is this high level of touch with the insurer. And increasingly, these specialty drugs, because they are expensive, will frequently have high cost sharing on the patient associated with them.
So you just actually did a really great job of defining what a PBM. So in our world and in our vernacular, we have a lot of acronyms. And so since we're now in this post-approval space, there are a lot of new acronyms, and PBM was one of them. So you just actually did a really great job of describing where the pharmacy benefit manager fits in this space. But you earlier used in response to another question that I asked, you talked about a P&T committee. Can you just talk a little bit about what that acronym stands for and where it fits in this equation as well before you move into the health insurance overview?
Absolutely, and I should have done it the first time around, so thank you for giving me the chance to catch up here. Health insurers will have a committee that is heavily clinical in its composition. It'll be comprised of physicians and pharmacists primarily, although it may also have people who think about costs, such as actuaries, also participating on this committee. And this committee will meet frequently during the year and consider new and emerging therapies that have become approved, and it will also consider data on existing therapies. Sometimes a drug that's already been approved becomes the subject of new studies that show that it may not be as helpful as initially hoped, and in rare cases, perhaps even harmful. And so the P&T committee, on an ongoing basis, looks at the list of covered drugs and may mid-year make some amendments, bringing a new drug on, or perhaps even sunsetting a drug mid-year if there's evidence that a drug is now harmful. That's one purpose of the P&T committee. But the other purpose, and the purpose that's probably more central to this discussion, is the P&T committee makes the recommendation, and it's usually a recommendation that insurers take, to determine what drugs to cover. And so depending on the particular insurance market, for example, Medicare or Medicaid or commercial insurance, there will be rules about how many drugs must be covered and what types of drugs must be covered. But even within those rules, there's a great deal of flexibility. And as an example of that, in the Obamacare markets, for example, there are classes of drugs, and every insurer participating in the Obamacare market must cover at least one drug per class. But in many cases, there can be a dozen drugs in a class. There could even be more than a dozen drugs in a class. So the P&T committee has that important decision of, short of making sure it meets the regulatory requirement, determining what to cover, and also recommending what type of cost sharing should be associated with that drug. We'll talk more about the cost sharing tomorrow, but that is the critical role of the P&T, is making those coverage recommendations for what the insurer will cover the following year.
Super, thank you. And then some of our families have been participating in DURs, or drug utilization reviews. How does the P&T differ from a DUR?
Yeah, we'll talk a little bit more about this tomorrow, but the key thing is that those types of reviews are individualistic and apply to an individual's needs for a particular drug at a particular time. And the decisions of the P&T committee apply to all people participating in the plan.
Okay, thank you.
All right. Okay, so we'll pivot now and talk about the second topic for this webinar, which is an overview of health insurance in the U.S. And I would just note, before we get into this topic in greater depth, when we talk about the Affordable Care Act, Obamacare, ACA repeal and replace, all of these topics that are in the news, we're not talking about health care per se. We're really talking about health insurance and access to health insurance. And so all of these headlines and the bold statements of political leaders are frequently less about health care, as in when someone goes to a hospital, they get access to a given therapy, and it's more about access to health care and how much the federal government's role should be in assuring that Americans are carrying an insurance card with them so that they don't have to confront the possibility of, for example, a medical bankruptcy. And that is that has been the topic around which so much of the healthcare discussion has been focused since even before the passage of Obamacare 8 years ago. Okay, and so with that, let's dive in and look at how most Americans are covered. And importantly, about half of Americans receive their health care coverage through their employer. Sometimes this is called the large group. But by far, the largest source of health care coverage in the U.S. continues to be through the employer. A great many Americans are also covered through government programs, and the two largest government programs are Medicaid, which is a state-federal partnership that finances health care for people with low incomes, and Medicare, which finances health care for people over age 65 and certain disabled populations. When we talk about Obamacare, Obamacare frequently applies to what insurance regulators will refer to as the individual market or the non-group market, and you can see that that's about 7% of the U.S. And so this topic that has dominated so much political discussion for the last several years is actually with regard to a relatively small segment of the population. Nonetheless, over time, the Affordable Care Act.
Mike, sorry, yes. Mike, I don't mean to hop on your slide, but and I know you know this, and we'll talk about it a little bit more tomorrow, but a significant subset of our population also is Medicaid eligible through the Katie Beckett waivers as well, due to the disability waiver. So that's a
yes.
you can follow closely.
So we will talk about that tomorrow. And Annie, that's an excellent topic to raise. There are people who are brought into the Medicaid program through particular waiver programs where in relatively small but high need populations have their needs met through Medicaid waivers, and we will talk more about the Katie Beckett program in webinar 2.
Great.
Okay. So broadly speaking, there are two families of health insurance products in U.S. healthcare, and we'll call the first one managed care. In managed care, a particular particular health insurer is the quarterback of your health care. There will be certain rules to how you receive your health care. There will be particular healthcare providers you can visit for full coverage or for partial coverage. There will be cost sharing that associated with using certain types of services. And if you have a long-term disease, there will be care management programs and care managers that the health plan might assign to work with you to assure that you're managing your daily health care needs successfully. You're getting to specialists when you need to get to specialists. You're taking your drugs regularly in the interest of halting the deterioration of a particular condition. Because when that occurs, not only does the patient stay healthier, but it also, frankly, can save money for the health plan to invest a little money up front in keeping its members healthy so that expensive hospitalizations, for example, can be minimized. And within the managed care family of products, the two most common types of products are in HMO, or a health maintenance organization, where the rules tend to be strict and where members can only see network providers, and a PPO, or a preferred provider organization, where there are looser rules and where a member can go outside of the managed care plan's rules and still receive some coverage from the managed care plan, but that coverage will be less generous than if they stay inside the managed care plan's network. The other family of products are sometimes called consumer-directed, and in this model or set of products, there is not a company running a managed care plan that's acting as your quarterback. Rather, you as the individual consumer are the quarterback of your own health care. Historically, the most common type of consumer-directed plan was fee-for-service. You have insurance that pays a percentage of your costs, and you go manage your own care. You see the doctors you want to see. If the doctors will write you a prescription, you take the drugs you want to take, and you are in charge of your own care, subject to the cost sharing of your what your insurance will cover. What was found with and fee-for-service at this point has largely left the commercial market. Very few employers use it anymore, but it is still used inside of the Medicare program, and it's still used in some state Medicaid programs. More common, increasingly, in the employer markets, in the commercial markets, are health savings accounts. In a health savings account, money is deposited into an account, and the patient or the consumer spends that money each year on their health care needs. If there's money left over at the end, then that money rolls over into the next year, and another contribution is made plus the rollover money, so the money has the potential to grow if the person is not using a lot of health care because they're frugal with their health care and because they're healthy. For people who have high health care costs, they will spend down that contribution, and then after they've spent down the contribution, it is out of their pocket up until they reach a catastrophic limit. Most health savings accounts come with a requirement that the consumer purchase catastrophic protection, and then the catastrophic protection might kick in at, let's say, $10,000. But if your contribution is from your employer is, let's say, $2,500 a year, and the catastrophic protection is at hypothetically $10,000, then the consumer could have $7,500 out of pocket in between. So health savings accounts are growing in popularity, particularly among younger and more healthy people. But for people with chronic diseases, for people with very expensive conditions, it may not be the right choice. Nonetheless, these are the two families of products when we talk about health insurance in the U.S. A little bit about coverage related to the Affordable Care Act.
Mike, can I just
Yes.
ask a question? So going back to your previous slide, just a couple other things. So we hear a lot about the health savings accounts and that there will be money put into the account to kick the account off so it doesn't come out of the consumer's pocket initially. Have you heard what those funding amounts have you heard ballparks of what those funding amounts are based on? And then my second question is, for members of the community who may need assistance managing their HSA accounts, have you seen any of those proposals be accompanied by sort of an HSA navigator? So for members of the community who may, have disabilities or may be elderly or may be vulnerable in some way, that seems to be sort of make those individuals vulnerable yet again, managing those accounts. So have you seen that be sort of thought of or accommodated for in those proposals?
Yeah, excellent question. So I'd want to make a distinction between HSAs as they presently exist in the market largely through employers and HSAs as they might exist in a Obamacare replacement legislation. HSAs as they typically exist right now through employers will have an annual employee contribution, and the employer makes the determination of what that contribution should be, but a contribution in the range of $2,000, $2,500 for an individual is common. It's more than that for a family. And there may be depending on the employer and how they're setting things up, there may be voluntary health coaching and care management services associated with that HSA. But that's at the choice of the employer providing the services and the entity that they contract with to administer the HSA. It's not a requirement. In terms of people with Duchenne or people with expensive conditions in general, the HSA might not be an attractive product if choices exist, in that there could be a large gap between if you know you're going to have considerable healthcare expenses in a year, then you can predict that you will exceed the employer contribution, and you'll purchase some type of catastrophic protection, and that will be helpful. But there's going to be a gap in between the employer contribution and the catastrophic protection. And if you have a choice and might be able to get a managed care product, the managed care product might do a better job at holding down the costs that you'll see in many HSA product offerings as they currently exist. Now, HSAs are popular. Are a popular healthcare reform idea, and we've seen the beginning of HSAs being introduced into Medicaid in the state of Indiana through a program called the HIP 2.0, and we'll see HSAs encouraged if the Republican majorities pass an ACA repeal bill. There will likely be provisions in it that encourage HSAs coming into the non-group market. And it's entirely possible that if we have a state licensing and using government funds to subsidize and make contributions into the HSA, then it's possible that the government entity might attach care management and coaching to that HSA. But that will be the decision of the government entity that is controlling those contributions.
All right, great. Thank you for the explanation.
Okay, we're going to talk a little bit about coverage changes due to the ACA. And prior to the passage of the ACA, there were a great many people, and the estimates varied, but 50 million was a frequently cited number of people without insurance. The ACA expanded insurance coverage through principally through two means. The first by expanding Medicaid, and the second by creating subsidies to allow people with limited incomes to purchase subsidized commercial health insurance through the health insurance exchanges. And with that, the ACA has dropped the number of uninsured in this country to about 30 million. Now, 30 million is still a lot of people, but it is less than the number that existed prior to the ACA. The ACA also created a federal floor for what health insurance can be in the United States. And there were certain consumer protections built in, such as insurers not being able to charge differing rates for people with pre-existing conditions, not being able to have insurance products that had annual or lifetime payment limits for treating a particular disease, creating what are called essential health benefits, which include a requirement that insurance that is ACA compliant must have a drug benefit, requiring catastrophic protection. But for all of these consumer protections that were built in, and there are several that there are several more that I did not list on this slide. Despite all of this, there's still a great deal of variation state to state, because while the ACA did create, for example, 10 essential health benefits, it's left to the state to determine the exact level of coverage within those 10 essential health benefits. And so that's just one example of where health insurance, despite having this federal floor still varies a great deal state to state. A little bit about what we might see in the future with respect to changes in drug benefits. We know that drug prices are a topic of great concern right now, and there are no shortage of ideas that are getting discussed here in Washington, D.C. with respect to ways to possibly improve consumer access to life-saving drugs and to control costs while doing so. And so I'll offer on this slide what some of those ideas are. The first few bullets on this slide, speeding up FDA approval process, permitting more off-label communications from drug makers with providers, and value-based purchasing arrangements are all less regulatory, less federal approaches to creating more products on the market, getting more choices to consumers. Presumably more choices to consumers creates market pressures to drive prices down. And so these first three bullets speak to ideas that are frequently popular among Republicans. The last four bullets, in comparison, expanding Medicaid best price protections, which is a rule that requires that the lowest price possible be given to certain safety net providers. We have a drug price transparency law in Vermont that other states are considering similar laws, which would require drug manufacturers that have large price increases to justify those increases through public reporting. We have a new law in Maryland that allows the state attorney general to intervene if there is a quote-unquote unconscionable price increase. And we have the idea of drug importation from foreign countries, all in where the same drug might cost less. These last four bullets tend to speak to market interventions by the federal government or by a state government, and these last four bullets tend to be more favored by Democrats. The two bullets in between, we know that the Veterans Administration has a very narrow formulary and uses that narrow formulary to negotiate steep discounts with drug makers. If you think back to a couple slides ago, we were talking about a particular drug class, and within a drug class, you might have a dozen drugs that are all relatively similar in their value. And in that case, if only one of those drugs is covered on the formulary, then the purchaser has a lot of leverage to demand very steep discounts from the drug maker. And there's a lot of concern about having the government go this model because it's such a large purchaser that at some point it's not, people worry that it gets close to quote unquote price fixing. But nonetheless, that's another model that is out there, as is the competitive bidding model, which is used right now in Medicare to purchase but medical equipment. And in the competitive bidding model, the government puts out a request for proposal in which it says we need X number of drugs to help with the following population under the following conditions, and everyone who wants to supply drugs to the government submits a sealed bid for how they'll do it and what their price is, and then the government makes a selection. So there are, as you can see, a great many proposals out there for how to begin to change how drug benefits are offered and how to contain drug costs. And I do imagine that in the next couple of years, we'll see at least a couple of these experimented with.
So, Mike, for the competitive bidding piece that you were talking about for Medicare, and you mentioned on the slide, it's for medical equipment. Is it limited to for the medical equipment bids, or is it for drugs as well?
It is right now. The competitive pricing model is only used for durable medical equipment in the Medicare program. President Trump has spoken favorably about this model and wanting to see it applied to Medicare Part D, but I believe that has not occurred yet, although the president has spoken favorably about it.
Thank you.
And then, Mike, can you talk about where the mortgaging of purchases for therapies, and we hear it talked more about with respect to gene therapy, for example, which is on the horizon for Duchenne, with clinical trials beginning, hopefully, by the end of this year in gene therapy for Duchenne. But can you talk about where that fits within these paradigms?
Yeah, that's an excellent question. There is a broad category of new purchasing techniques that collectively are sometimes called value-based. And to make value-based make sense to people who do not live this world, if I owned a car and needed to get my brakes fixed, I would go to a mechanic. The mechanic fixes my brakes, charges me $200. If the brakes break again in 3 months and I have to go get the service again, I get charged $200. And if again 3 months later I need to go back, I get charged $200. So I have paid $600 for 9 months of having my brakes work. In another model, we might work with the mechanic and say, if you can give me a year of trouble-free brakes, I will give you $400. And if you're the mechanic, you can look at this and say, wow, I'm taking a little bit of a risk here, but if I do a good job the first time around, if I deliver a higher value for one service, that's worth it for me. I take a little bit of risk. And at a very simple level, that is the difference between the way an insurer pays for drugs now, which is I'm buying a collection of pills from you, and here's the cost, and a value-based model where I'm saying you can keep my people healthy for a year, and so I'm going to give you a base cost, and I'm going to give you all kinds of opportunity to demonstrate the value of your drug, and you can get paid more when you demonstrate the value. And when we talk about the mortgage model, that is even a step further, where we're saying that a particular therapy, let's say a gene therapy, is extremely expensive because we're going in and, for lack of a better word, we're fixing someone's DNA. And that costs a lot of money. And the way we're going to pay for that is over the next 30 years making payments back in for this very expensive investment up front in the belief that in the long run, that upfront investment is worth it. And all of this is really at the earliest stages. There are just to the best of my knowledge at least, there are just a handful of value-based purchasing arrangements at this time between health insurers and drug makers. But there's a lot of excitement about the way that value-based arrangements will align incentives and in the long run result in better care and cost savings at the same time.
Great, thank you.
Okay.
That's a great analogy.
And with that, that takes us through the prepared material for Webinar 1. And Annie, I'll turn it back to you for closing comments.
Well, since you were gracious and let us weave questions all throughout your presentation, I don't think you left any question unanswered. I think what we will do is, as we're closing this, first of all, thank you, Mike, for really you did an amazing, thorough job. And I know we had said at the beginning that we were aiming for maybe a shorter webinar, but the topic and the information you gave was just absolutely extraordinary. And I feel like anyone listening to this will hopefully be able to take lots of notes and come back and listen to this again and again. And we will leave this up on our website as long as this information remains accurate. And then fortunately for us, we have Mike and the team at Faegre on our team, and as these policy changes continue to evolve and change, we will come back and update this information and conduct future webinars as needed. But thank you very much for not just the explanation of what's happening now, but what can be happening and how this will potentially be changing in the near future. We do want to make sure that our community knows that we do have an Access Resource Center with lots of resources available for the community. Again, we are trying to keep these updated as this space is evolving. We now have 2 approved products for use in Duchenne, drug therapies for Duchenne. And this resource center is aimed for use by the patient community, the provider community, and payers are utilizing this resource center. So if anyone listening to this has tools and resources or knows of sites that would be useful to load into the resource center that is not currently here, if you can send that to us, we'd be happy to load it. But that is where this information will live. So thank you, everybody, for joining us. And please know that PPMD is here to continue to serve you as you navigate access to approved therapies. And thank you, Mike.
Thank you.